Joining us today, I'm very happy to say, is Donna Skerrett. She is the Chief Medical Officer of Mesoblast, who is going to discuss the company's promising cell therapy for GVHD. Dr. Skerrett. How are you?
Good morning. Thank you for that introduction. It is a condition that's very dear to my heart. I practiced hematology for about 20 years and did a lot of work in blood banking, and there's nothing more frustrating as a physician as being in a position where you've run out of things to offer a patient. And then you have to have a talk, and that's just a place where we hope not to have to go too often. So I am thrilled that in recent years we have made sufficient progress with mesenchymal cell therapy that we can address a serious condition like graft versus host disease. So as you've heard, I'm Chief Medical Officer of Mesoblast, a regenerative medicine company that develops adult stem cell therapies for purposes of tissue repair and regeneration. And I'd like to show a brief video to describe our technology.
Mesenchymal lineage adult stem cells, MLCs, are rare and potent cells that play vital roles in maintaining health and respond to signals associated with tissue damage. MLCs are taken from healthy young adult donors from various tissue sources, including bone marrow. MLCs are isolated and expanded to create master cell banks, which generate thousands of readily available therapeutic doses for use in patients without the need for tissue matching, resulting in an off-the-shelf product that potentially will be available on demand. Each product is packaged into vials, frozen and then transported to medical facilities for potential use in patients in clinical trials worldwide. Mesoblast is targeting a broad range of diseases with high unmet medical needs, including advanced heart failure, chronic low back pain due to disc degeneration, and inflammatory diseases such as rheumatoid arthritis. Additionally, Mesoblast mesenchymal stem cells are being evaluated to treat acute graft versus host disease, a life-threatening inflammatory complication of allogeneic bone marrow transplants.
Thank you. So I look at that video and it's about 45 seconds, and it represents about 10 years worth of work. But today I'm here to share with you the progress we've made with the indication graft versus host disease. And as you've heard, this is a serious complication from allogeneic transplantation. Each year, about 30,000 patients undergo an allogeneic transplant. 25% of them are children who have leukemia and other serious bone marrow disorders. And as you've heard, this is not a simple process. To undergo a transplant, you require a donor who should be matched to the patient on transplantation antigens. And a donor search, identifying that donor, can take months. Sometimes it's very frustrating if a related donor is not found, then you need to go to the registry for searches. And sometimes even in the registries, it's difficult to find a donor. So that's the first major hurdle a patient undergoes. And then the procedure itself, as you've heard, it's serious, it's complex. It requires high doses of chemotherapy to treat the underlying disease, and then also to allow the patient to accept a new blood and immune system from the donor. Until that donor transplant and grafts, the patient is at serious risk of infections and hemorrhage. And then the graft comes in, and most of us would think we could sigh at that point. But after engraftment, patients are then at risk of developing this serious complication, GVHD. Acute graft versus host disease is serious. It's a severe immunological reaction that occurs in bone marrow transplant patients, and it causes extensive disease involving the skin, liver, and GI system. It affects about half of allogeneic bone marrow transplant patients, and there are no approved treatments for this in the U.S. The first-line therapy is high-dose steroids, and response rates to steroids are 20 to 50%. So for those patients who do not have a good and durable response to steroids, additional second-line agents are used. But the issue with second-line agents are none of them are approved, and there's no consensus around what's really effective, and many of them have considerable risk. So when physicians have a patient who has not responded to steroids, there's major concern about what to do next and how this is all going to turn out. There's a clear need for new treatment modalities for steroid refractory GVHD. It's progressive, spontaneous remissions do not occur, and severe refractory GVHD has a median survival of less than 80 days. It's extremely painful and it's debilitating and often leads to death. So as you can imagine, as a patient who's gone through the ordeal of a transplant in hopes to cure a serious disease, to then have the onset of GVHD is truly heartbreaking. So why are mesenchymal lineage cells being developed to treat acute GVHD? In GVHD, the transplantation regimen causes a lot of damage to the tissues and a widespread inflammatory response. And the bone marrow transplant donor cells react to this inflammation. They also react to differences between the donor and the recipient. And they proliferate and they attack the host. So mesenchymal lineage cells have a number of properties. They inhibit this donor T cell proliferation. They decrease secretion of the inflammatory cytokines that cause a lot of the tissue damage. They also induce a type of cell, a T regulatory cell, that helps to calm down that inflammatory response. And what we've seen in vivo studies is that when you infuse these cells, they have certain receptors and markers that allow them to know where the inflammation is, and so they home or distribute to the areas of inflammation. They also can be used in a recipient without the need for matching. So you've heard about with a bone marrow transplant, you need to find a donor who's matched to the recipient. But with mesenchymal lineage cells, they lack certain molecules on the surface which will initiate an immune response between donor and recipient. So they can be used without matching and without the need to immunosuppress the recipient. And additionally, multiple infusions of these cells can be given without an observation of increases in B cell or T cell responses. So you can keep giving them without concerns about the recipient developing any severe reaction to the MLC infusion. So these are all properties that allow MLCs to be developed for widespread use in indications like graft versus host disease. Our experience with this condition goes back over many years, and a number of patients have been evaluated through regulated access pathways for investigational purposes. We've done clinical trials in this indication. We've also conducted a large expanded access protocol in acute GVHD. And we've offered cells under emergency IND, so often patients are not eligible for a clinical trial or don't have access to a trial, but are truly in need of a therapy because they've exhausted other therapies. And for those circumstances, we work through an emergency IND pathway. So I'd like to share some of the data with you today. The first set come from a randomized clinical trial of patients who failed steroid therapy for graft versus host disease. Now, this was a study that was randomized. It planned to and did enroll 260 patients, but only 28 of those patients were children. And what happened early on in this trial is that patients were enrolled, literature was being published on the promise of mesenchymal stem cells in graft versus host disease. And it became a real dilemma for physicians and for patients alike to consider randomization into a trial where a patient with this serious condition might get the control agent. And that's a particular dilemma for young children in clinical research. So subsequent enrollment of children in this trial was curtailed, and an expanded access protocol was open, and I will describe that in a minute. Under this protocol, patients received infusions twice a week for 4 weeks, and then they were assessed at the end of 4 weeks. And the way we evaluate the assessment is to look for the response at day 28. Has there been a complete response or elimination of the GVHD symptoms or partial? And either complete or partial hold promise for improved outcome for this condition. So what was seen in children in the study was that MSC significantly improved the outcome at day 28, and that correlated to a survival advantage. And so that was seen very early on in this protocol. And likewise, cells were well tolerated, and overall improved responses were seen in patients who had liver, GI, and high-risk disease, as well as the children I've just described. Now, most of the children who've been treated with GVHD, who've received mesenchymal stem cells, have been treated on an expanded access protocol. This is a large program that was conducted over many years. 241 children have been treated, and they've received up to 2,434 doses combined, so multiple infusions were given to children. They received the infusions twice weekly for 4 weeks. In some cases, extended therapy was provided. The overall response rates, again at day 28, were 65% overall. And what we see here in this survival graph is that patients who responded, and that was determined at day 28, had significantly improved survival. It increased their survival to 82% at day 100 compared to 39%. So for a condition where severe GVHD is known to have this dismal outcome, this is showing us that we can look early on, see if patients are responding, and know that we can expect that response to extend over to survival at day 100 and beyond. We're currently conducting a phase 3 registration study to provide the data needed for an approval pathway in the U.S. for GVHD. It's a multi-center study involving at least 60 pediatric patients who have acute GVHD that has not responded to steroids. The patients have severe disease, and the endpoints are looking at response at day 28 as well as survival. The data shown to support this type of study are shown in the right panel. Again, we're looking at patients who have not responded to steroids, and some of these patients were treated on expanded access and others in the randomized trial. But what we're seeing here is that we can expect response rates to be quite favorable for these patients and correlate to survival benefit as well. So now I'd like to share with you what happens when patients don't have access to a clinical trial or are not eligible. And this happens. And when we're at a stage of development where we are now, we often hear about patients who have exhausted other therapies. And so for that reason, I hear from physicians quite often. And what I'd like to do today is share with you one patient's experience through what we call an emergency IND pathway. And this experience is presented by her patient, her physician, who is Dr. Paul Carpenter, who is director of BMT at Fred Hutchinson Cancer Research Center and professor at the University of Washington. So now I'd like to share the video.
Graft versus host disease, simply put, is an attack from the donor cells, given that the graft in a marrow or blood transplant is a liquid. It can spread all around the body, and it attacks the body that it sees as foreign.
My name is Shelby Bruce. I have 4 children. London was 5 years old when she was diagnosed with acute lymphoblastic leukemia, just 2 months after her birthday. The treatment that London received was the standard ALL treatment. She was almost completely done with her 2.5 years of treatment. And then on New Year's Eve, 2013, we found out that the leukemia had come back.
London is a child who's dear to my heart. I met her in the very beginning, before she even came to transplant. I did her initial consult, and she had a very high-risk leukemia. And what was particularly difficult about her case is she had a cord blood transplant, which is, in the general rule, less likely to cause severe GVHD. But then she relapsed in her bone marrow with her leukemia very early after transplant, and our strategy at that time was to discontinue her immunosuppression and give her a round of chemotherapy, which she tolerated, put her back into remission. But as she recovered with a remission bone marrow from her leukemia, she then developed life-threatening GVHD.
Just before her 90-day mark of post-transplant, that's when London started to exhibit signs of the GVHD. She had bleeding as well as the diarrhea.
When any patient has abdominal pain and they're bleeding from their intestine, needing blood transfusions because they're bleeding, that is when you think, I'm not sure how this is going to go. Especially when you failed all of your second-line therapies.
And it just wasn't getting better. Even with the high-dose steroids, the ECP, nothing was working. She's always been a petite, small child, and she gained 25, 30 pounds, so that was hard for her to deal with. I found out about the adult stem cell treatment for London through help of my aunt who lives in the Seattle area as well. We both got online and were trying to find anything that would pop up regarding pediatric GVHD.
Mesenchymal stem cells are basically collected from adult donors. They're a product from the blood and marrow system. And she had a remarkable dramatic response. Within 28 days, she had no further abdominal pain, no diarrhea. And then I just saw her this week, 5 months nearly since she received the MSCs, and she's doing great.
Today, London is doing amazing. She is a healthy, happy little girl who loves to play with her sisters, play with friends, play outside, go to church, just do normal kid stuff. She's extremely happy to be out of the hospital.
Based on the pediatric data as I have seen it, if I had MSCs readily available, I would certainly consider using them a lot earlier in the game than where we've been able to use them, because it's not commercially available. We have to fail our general second-line therapies and then jump through a lot of hoops to get compassionate use approval.
Mesoblast cell therapy has saved London's life. We truly believe that London is here with us today because of God and the treatment she received. The Mesoblast cell-based therapy is a wonderful, non-invasive treatment, and we're so thankful and blessed that she was able to receive the cellular medicine. I just pray that it can be widely used to save other children and adults' lives around the world.
So that's London's journey. And my goal is to do whatever it takes to make sure we can provide widespread access to patients who develop GVHD, so that physicians like Dr. Carpenter and Dr. Girold and Dr. Kurtzberg don't have to have that talk with patients when they've run out of options. So we're currently conducting the phase 3 trial. We are putting in place a type of contract manufacturing that will allow products to be available for trials and subsequent commercialization, also as seen in the animation. I'm very happy to share that earlier, at the end of 2015, actually, in Japan, a product through a Mesoblast licensee received the first full approval of an allogeneic cell therapy, and it's for the indication of graft versus host disease. So TEMCELL was launched in February of 2016 by JCR Pharmaceuticals for children and adults with acute graft versus host disease. in Japan. I'd like to thank the organizers of this conference. It's a wonderful opportunity to be able to share science and the patient experience together with a group such as this. And I'd also like to thank all of my colleagues at Mesoblast who spend timeless days and holidays included, making sure the trials proceed, that we meet all of our goals, and that we are able to respond to physicians and patients in need. So thank you very much.